So, good afternoon, dear ladies and gentlemen, dear colleagues. A warm welcome from Klinikum Arnsberg. My name is Michael Lichtenberg. We welcome you all to this session today, 2-in-1 expert course, challenges in treating acute DVT and new and efficient techniques for recanalization of complex diseases in the lower limb vessel. My name is Michael Lichtenberg, and together with me is Professor Markus Cato from Krefeld. On my left side is Dr. Ralf Langhoff from Berlin, and also Dr. Marco Manzi from Italy. And later on we will also be joined by Professor Marianne Brodmann, who will later give a talk on BTK intervention. The idea of this session today is to talk about two topics. On one hand, we would like to talk about thrombectomy in arterial and venous obstructive disease. And on the other hand, we would like to give you an overview of new and efficient technique, especially with a new balloon device, the AeroGPS device for recanalization of complex diseases in the lower limb vessel. We already prepared two cases which we recorded yesterday in our clinic. We will later show you these cases. But first of all, we would like to start with a talk given by Markus Cato, who will give you an overview about rotational thrombectomy, the Rotarex device. After this, we show you a Rotarex case, and after this, also a short introduction of deep venous thrombosis thrombectomy using the Esprex scatter. So, I would like to ask Markus to give his first talk on rotational thrombectomy with the Rotarex device.
Thank you, Michael. Good afternoon, ladies and gentlemen. My name is Markus Cato, and it's my pleasure to share our experience in mechanical thrombectomy or debulking in patients with lower limb ischemia. So, lower limb acute and subacute lower limb ischemia is induced by thrombotic emboli or local thrombus formation in pre-existing atherosclerotic lesions. This can be tackled by surgery, by lysis, or nowadays by endovascular therapy options. These can be subdivided into intraluminal or extraluminal approaches, and balloon and stand PTA techniques as well as atherectomy devices are particularly indicated for stenotic lesions, while for occluding vessel aspiration, lysis, or rheolytic thrombectomy devices, laser atherectomy and mechanical thrombectomy are available. All of them have their own advantages and disadvantages. And I want to go a little bit into detail. In our experience, aspiration is limited due to low success rate, particularly in elderly thrombi or in occluded vessels with a huge amount of thrombotic material. While lysis is associated with complications like bleeding. All patients have to be therefore monitored on an intensive care unit, and also angiographic controls are mandatory. Rheolytic thrombotic devices are also limited in efficacy in older thrombotic material. Laser atherectomy is also limited since it also only allows to establishes relatively small recanalization tract, and both devices come with a quite huge power unit and is quite expensive. So I want to introduce you to a mechanical debulking device, namely the Rotarex S device, which is available in 6, 8 and 10F. It consists on a catheter tip on a shaft, and the shaft end is connected to a mortal handle. This includes the magnetic clutch and an electrical motor, which is driven by a quite handy power unit which easily fits into a small suitcase. The catheter tip consists on two cylinders. One is a static cylinder and an outer rotating cylinder which is connected to a helix which runs through the catheter with a rotation speed of approximately 60,000 rotations per minute. And this device includes 4 functions into one, namely detachment, fragmentation, aspiration, and also removal of the thrombotic material. I want to illustrate you the function on a short animation. Can you start the video, please? So you can appreciate the outer cylinder and the inner cylinder. The outer cylinder is connected to the helix, which runs over a guide wire. Both cylinders have this fenestration, and once the guide wire is passed through the occlusion, the rotating cylinder acts as a drilling bit and detaches the thrombus. The detached thrombus material gets aspirated into the thrombus by the vacuum inside the catheter and gets fragmented by the shearing movement of the two cylinders. And finally, all the material gets aspirated and removed out of the body according to the principle of the Archimedean screw. This is one case we did last week, a 70-year-old female patient with acute onset on pain in the left leg. And you can see a quite long occlusion of the superficial femoral artery in the Hunter's canal. You can appreciate the quite typical end or the proximal end indicative of thrombotic emboli, and you can also see the multiple collateral vessels. We hesitated a little bit to perform the mechanical thrombectomy or debulking in this case due to the sparse runoff vessels at the lower cuff, but we did it since we saw a lot of collaterals. So the long occlusion could quite easily pass with a guide wire and catheter, and these are the results of the 1-2 passage of the occlusion with the Rotarex catheter. So you can see that there are some residual stenosis which however did not seem to be hemodynamically significant, since you can see the almost complete disappearance of the collateral vessels. Here's another case where we had a complete occlusion of the external iliac artery in a patient which was treated with stent PTA several years ago. Also in this case we performed a thrombectomy or debulking using the 10F Rotarex catheter. We could manage to perform a recanalization tract, and we did also in this case another balloon PTA, and this was a final result with a almost complete recanalized external iliac artery. So in conclusion, the Rotarex debulking device is a quite straightforward debulking device which is a manageable complexity. It is easy to learn, it's a very fast procedure, and is associated with very low complication rates. It allows to demarcate the underlying lesions if there is any, and allows to treat the occluded vessel with lowest stress possible. The procedure do not need any intensive care monitoring of the patient and doesn't need any controls in the angiography again. It minimizes therefore the hospital stay and costs. On contrary, like almost every other debulking device, the passage of the guide wire is a prerequisite or precondition, and one has to be careful in calcified lesions, since if a calcified lesion is sucked into the catheter, it might lead to a vessel perforation. Peripheral embolization is a complication which can happen, but in our experience it can easily be handled by a simple aspiration. And cost is another issue, but at least in Germany I can tell you that it's well represented in the German reimbursement system. So all in all, I must say that the Rotarex S catheter became very handy and popular in our institution, and we use it for acute and subacute occlusions where guide wire passage could be easily performed. Thank you very much.
Thank you, Markus, for this nice overview for the usage of the Rotarex device. I would recommend for the audience who's joining us and for following us, we have the opportunity that you can send questions into a live chat room here. We have this here on our screens, so if there are any questions from the live web followers, you can send them and we'll try to discuss on that. We just received one question, and maybe this question is very important, Markus. How old could be the occlusion situation for thrombolytic situation, which you should only treat very fresh thrombus? Yeah. What do you think? How old can the thrombus be for the Rotarex?
So actually, I cannot mention any precise data. At the beginning, we just treated fresh thrombus, like with rheolytic thrombotic system, for example. But if we became familiar with the system, we pushed the envelope forward, and nowadays we also use it in subacute and also chronic occlusions if the guide wire or the catheter can be passed through the occlusion. This is our experience nowadays. Mm-hmm. So actually I cannot say 4 or 6 weeks. It can be 3 months, for example, if it's fresh, or let's say if it's soft.
Okay. What size of catheter do you recommend? It's better to use always an 8F for the SFA, better go for 6F. How do you measure size of the Rotarex?
So for most SFA lesions, actually, we go for the 6F catheter, I must say. The efficacy or capacity for the catheter is actually much more, or actually much more depending on the speed you use the catheter. So you have to give the catheter time to aspirate the fragmented material. So and our experience is also that the complication rate decreases with the speed. So with a gentle use of the catheter. So just go a few centimeters per minute is recommended.
Mm-hmm. Okay. What about filter system? There's a question here coming up. Filter system, is there something you would recommend, or because of the Archimedes principle it's not need because of the huge amount of sucking of this catheter?
So actually we do not use any filter systems. It makes the procedure much more complicated. So to keep the whole procedure straightforward, we actually go just over guide wire, and if we have a little thrombus which gets embolized in the periphery, we just use another aspiration catheter to remove it. So we haven't seen so far a huge amount of embolic material. So the aspiration system, the Archimedean screw systems seems to work quite good, and we are actually very satisfied with the system. Yeah.
Okay, just maybe a question here from the chat. Although you just give a lecture about arterial system, so there are just a lot of questions concerning the deep venous thrombosis, which probably is just of great interest.
We'll cover this later.
Okay, so just to be sure that a lot of those questions concerning now venous problems.
Yeah, I think because of that, because of the high amount of venous question, we'll now forward with a record a live case, and after this we'll start with the use of the venous thrombectomy with the Asprex. So we will start now with the recorded case where you can see a patient who was treated with the Rotarex device, And of course, you can also send questions for this recorded case during the case, and we will focus on this question, of course. So good afternoon, dear colleagues. Welcome again back to Arnsberg Clinic. My name is Michael Lichtenberg, and together with me is Dr. Marco Manzi. I think everybody of you knows Dr. Manzi, and we are going to perform this case here together. Just want to briefly summarize our next patient. It's a 51-year-old male patient who had a bypass graft implantation 7 years ago, and now he experienced problems while walking. After 50 meters, he felt a leg pain in the lower part of the leg, and as we performed ultrasound, we saw that there's a fresh to subacute occlusion of this bypass graft, and we now intend to recanalize this bypass using rotational thrombectomy, the Rotarex system, to really perform a mechanical thrombectomy of this occluded bypass graft. For this purpose, we will go on from contralateral side, perform a crossover maneuver, and then go ahead into the artificial bypass. So for the first step, I just want to briefly introduce you to a new ultrasound machine from Siemens, which is an machine which is cable-free, as you can see here. And this is connected to a monitor using Bluetooth technology. And with that, we can easily access and puncture a femoral system here. Oh, yeah. Okay, after we have performed now the angio of the left side, as we can see, it's a P3 bypass situation with a tip artery going downstream. We are now doing a crossover maneuver, taking over a crossover sheet, 6F sheet, and then doing also a selective angio to really find the distal part of the bypass, and then try to recanalize this bypass. So we are now doing the crossover maneuver. Okay, now it's coming. Okay, the first step I think would be now to get into the bypass and to bring a wire down, and we will use a support catheter to navigate us downstream. On a good way, huh? Okay, I think you are entered already somewhat. I don't know what, but I think
Yes,
it's a
this
bypass.
is the bypass.
Yeah.
And it's very, very soft.
It's very soft. So let's bring it down. Okay, so bring it down.
So the distal anastomosis should be on P3.
Yep.
Okay.
Okay. Okay. It's not too bad.
Okay. It's like...
Yeah, it's angulation there. Huh?
So I would like to... My name is Marco Manzi, and I would like to discuss the aspect of this approach. We decided together to perform a contralateral approach with a 6 French sheet, long sheet, and we had some difficulties during all the procedure in having a stable position with the sheet because of the strength involved were really many, and it was difficult to advance the supple catheter, maintaining a good position with the sheet.
Yeah.
So, do you think, Michael, this procedure could be performed with a direct antegrade approach in the common femoral artery? Which are the advantages or the risks, adjunctive risk to the procedure?
Yeah. Yeah, I think you're totally right that we really had a problem with the crossover maneuver in this particular patient. The problem, and that's why we decided to go crossover, is that we did not have a stump of the bypass origin. So, of course, as a trick, we could have used ultrasound guided puncture directly of the occluded bypass, maybe for an antegrade access, or a high common femoral artery access, ultrasound guided. Yeah. Afterwards, I would say the crossover maneuver in this particular case was quite difficult, and of course antegrade access is always much more easier. Ralph, if you see this case, what would you say? Also more better to go antegrade, huh? Or
yes, honestly speaking, I would just also go crossover, maybe just to take stronger sheaths. To have a little bit more support, but I'm always afraid that I may miss the offspring of the bypass, even with ultrasound guidance. I think sometimes your landing zone is very short, and as you have to get a bulky system into the bypass, so I would always be afraid that I may lose the sheath for the antegrade puncturing. But just to control it, it's more easy in the case, but if it is a flush occlusion, I always go contralateral.
Marcus, do you agree with this approach?
I also would.
My question is, if we did, we had a distal embolization, for example, and so we need to aspirate. And with a crossover maneuver, is the emboli could be very far away from our access, so could be really difficult to arrive in the foot and aspirate. Yeah. So, but I don't know. I don't have experience with this system. So probably the amount of complication as distal embolization is not so high, and we could manage with this approach.
Definitely.
It's just to discuss the pros and cons of the two different approaches.
Yeah. So sometimes if we just face an embolization, we go for a second puncturing. We would go just leave the crossover access and then go for an antegrade access if we just feel that we need a larger sheath, or that monorail aspiration system like Diver or Eliminate would not be efficient. We just would go for antegrade puncturing additionally.
Okay. So we are now coming in this case, and maybe this is the important part. Maybe we can turn on the sound again. It's now preparing the rotorex for a thrombectomy of this bypass, and this is the magnetic clutch which drives the catheter, the Archimedes catheter inside here. And this is a 6F 135 centimeter long catheter, so that we have the chance to go crossover and use this catheter to really do a thrombectomy of the bypass graft. Before usage of the catheter, you really have to flash the catheter. You can do it like this. hold it like this, put a syringe on the tip of the catheter and just inject some saline, filling the whole catheter with saline, and then you're done. And then the next step would be to connect the catheter with the driving machine, as you can see here. Just put these both parts of the catheter together like this, and now the machine is ready for usage, and we now insert it into the bypass. We're getting blood here. Okay. Now we can really impressively see how this catheter works. It really sucks out the contrast, which is here in the... What you can see now is how the efficacy of this catheter system. We filled this bypass with contrast, and this thrombus filled with contrast is now really detached. Here you can see the removal of the thrombus of the bypass with the Rotarex catheter. So this is highly efficient.
So can you comment on the size? So 6 or 8 French system?
I think this is a very important question. This is a bypass with a diameter of 8 millimeters. For this size, it's definitely better to use an 8F approach. But in this case, it was very, very difficult for crossover. So that's why we had to use the 6 French Rotarex device. Of course, 8F is the preferred size of this catheter for this bypass indication. I would really recommend, if it's possible anyway, to use an 8 French system. In this case, we were forced to use 6F because of the problems with the crossover maneuver. Okay, that's
Okay.
Maya. Okay, take it down. Yeah, okay. Okay. Perfect, thank you.
There could be a stenosis.
Okay, just a question. So do you clean in between your sucking maneuver, or do you just go as long as there's blood flow? Because I think you just contained everything in a bag. You didn't show so far, but if there's blood flow, you go ahead, or do you clean in between?
Yeah, you always get the feedback from the catheter. If there's a problem of stacking of the catheter, too much thrombus amount, then the machine gives you feedback, and this is the moment we take out the catheter, clean it, and bring it back into the patient. It depends definitely on the thrombus amount, on the organization of the thrombus, and I would recommend to clean it in between, in every second run.
And to clean it means just to bring it out and then put it into a water bed and then just
activate
it.
Yeah. So I think next step is there is something going on in the proximal in the proximal anastomosis of this, definitely.
You want to repeat the inflation?
Yeah, here once, and then we go in with the Rotarex again. Okay. So.
Nicole.
Just double check. Okay. We have to, oh, you see now where the stent opens, the subtotal occlusion. We have an inflow. So.
Yes, we have still material inside.
Yeah.
Nimm für einen dicken Draht, ne?
Oh, that's a short one. So what you see now is that we implanted a stent in the proximal part, at the proximal anastomosis. The reason for that was that there was a high-grade stenosis, and when we inserted the Rotarex catheter, the catheter was not able to really suck blood and thrombus because of no inflow. And this catheter definitely needs flow, otherwise it runs dry, and therefore it can really get stuck. And the reason for stent implantation was now to get more blood into the bypass. And after this, we really could very easily perform two other very efficient thrombectomy runs with the Rotarex device. So always take care of enough blood flow so that the catheter can work with that flow to really detach thrombus. This is very important.
So that's why so actually that's why the reason why the catheter works more efficient if you work in an antegrade manner compared to retrograde and retrograde approach. Yeah. And it's also recommended to put some water through the sheath.
This is especially for venous patients, very important, where the flow is, of course, very, very slow. And then,
because of this,
we have to change the wire, of course, but we can use the balloon for changing then. And
yes.
so then we have two in one.
If the balloon passes.
Yeah.
If not,
then we take the other option. 1, 2, 3 millimeters. Okay. Yeah, let it dilate here. Okay. There's a very important question here from the web. What other options, therapeutic options for all maybe we can all discuss it, for this particular situation, what you can think of, other options for endovascular treatment? Localized therapy, is that an option, Rolf?
I think it's just an option, so it depends on how old this is, so sometimes you don't know because patients maybe just have some claudication just beforehand due to a stenosis of the bypass, but I think thrombolysis would be just an option, and then if you do not succeed, just remove it by aspiration or laser or stuff like this. But just for bypasses, I think Rotarex is just really probably the most elegant option because it's quick and fast.
Yeah.
I would agree. I would agree because thrombolysis usually takes a very long time in bypasses. So you can start with that if you want to stay a little bit cheaper. But on the other hand, I think at the end of the day we'll end up with something like that.
Yeah. And we have to remember this occlusion seems to be for 6-7 months.
Okay, then
So then there is
there is no discussion about that. Then I would have done it the same way.
Because the patient felt claudication for more than a half year now, and he was treated conservatively. But now the walking capacity dropped to 30 meters, 40 meters, and this is a very young patient. 63. He was born in 63, and he's very active.
Why did he get the bypass at such a young age?
I think we need another session to answer this.
As said, very active patient.
Yes.
And don't you think that there is also a problem at the distal anastomosis?
This is
because
very, very
when you see the aneurysm there,
So what we found out, because we did not have a lot of information about this patient, and because he was treated far away, what we know is that this is a P1 artificial graft bypass, and they did the ring stripper therapy of the popliteal artery. And there was a subtotal occlusion also of the popliteal artery, and that's why we decided to stent this part. Otherwise, the therapeutic options in this treated popliteal artery would only be not that efficient. That's why we implanted a stent distally to the distal anastomosis. So we now found access to the tibial artery there.
Can you lift the wire?
Yeah, okay. Can you still have the wire?
To insert a second wire into the peroneal trunk in order to achieve a second vessel to have a much more favorable outflow in the leg. But you know, as you can see, there are many metallic clips around that area, and the resistance of the occlusion was very, very high. It was not possible to perform a dissection nor crossing the lesion intraluminal or with a tip load wire. So we decided to achieve a good outflow just in the anterior tibial artery, and we supported the outflow with the stents, as you can see. So the impression was that probably there was a surgical maneuver in that area, because that impression to have a cicatricial tissue in that area was really, really strong.
So these are the final steps of this endovascular procedure. You see the outflow now, which we think that it was quite efficient for this patient. And what I can tell you, this morning we followed this patient, did an ultrasound. There's still a very good inflow in the tibial artery. So I think this patient has a very good option now for training, and we will keep him, of course, under control for the next months. So.
Michael, may I just
yes,
ask a question? You were telling us before that you had this tight stenosis at the proximal anastomosis, and it seems also on the distal one. Did you consider an DCB as an additional treatment to the stent treatment?
Yeah, very, very important question. What we did is to implant a stent, and we post-dilated the stent with the DCB.
Okay.
Yeah, to maintain this patency. Okay, I think we have to move on, and now we come from the arterial side to the venous side, and beside of the Rotarex device, there is the Aspirex device, and I would like to give you now a short overview for the use of the Aspirex device in patients with acute and subacute deep vein thrombosis. So, what we know, there are a lot of patients in Germany suffering from deep vein thrombosis, a complication of pulmonary embolism. But what we definitely also know here from this estimation from 2004 is that a lot of patients suffer from post-thrombotic syndrome, because these patients are only treated with compression therapy and anticoagulation, and especially for iliofemoral deep vein thrombosis. This seems to be not an efficient treatment, as the patency And the recanalization of the iliofemoral system is not enough after this conservative treatment, and these patients are on a high risk for post-thrombotic syndrome. So this gives, of course, from my perspective, the indication for the thrombectomy approach for these patients. And here you see some indications for proximal venous thrombectomy procedures which we performed. Especially in young patients, as you can see on the left side, 23-year-old female patients, we often have to think of a May-Turner compression syndrome associated iliofemoral ascending, descending deep vein thrombosis. Of course, there are also cancer-associated deep vein thrombosis, or in old patients or previous operate patients, lymphocyte compression syndrome can cause proximal deep vein thrombosis, iliofemoral thrombosis. And what we definitely know that 50% of patients develop post-thrombotic syndrome after proximal DVT. And already in 1990, it was clear stated that proximal DVT is associated with PTS in every second case. So this is the indication for an effective thrombectomy approach in these patients. And beside of the Rotarex device, which Markus already introduced us, there is the Aspirex device. And the difference between the Aspirex device and the Rotarex device is that the Aspirex device has no turning tip, so that there is no chance of harming a vein during thrombectomy. But the principle of the catheter itself is the same, the Archimedes principle, creating a high blood volume aspirating. Depending on the size of the catheter, as you can see in the low part of this slide, the 10F system can aspirate up to 130 milliliters per minute of blood during the run. I want to show you a two-center experience registry for DVT thrombectomy, which we performed together with the University Clinic of Rostock, where we analyzed the performance of this catheter in different indications, mainly in patients with descending and ascending iliofemoral thrombosis. And here are the experience of the Rostock group. They treated 26 patients. The mean age was 50 years. 21 of these patients had an iliofemoral DVT. 2 of them with a descending IVC thrombosis, and they also treated 3 subclavian thrombosis, only with Aspirex. What is very important that the stent rate, especially in patients with iliofemoral DVT, was high, 95%. But in the combination of detachment with this Aspirex device and together with stent implantation, the technical success rate was 96%. They only failed in 1 patient where they had to give thrombolysis therapy overnight. In all other patients, no thrombolytics had to be given, especially not a prolonged thrombolytic therapy. They did not have any severe adverse events, no bleeding, perforation, or pulmonary embolism events. Here's a typical example of the Rostock group. Patients with a descending DVT, and they performed an thrombectomy with a 10F system, and after this they stented the underlying reason, a compression syndrome, and you can see afterwards a very good inflow after efficient treatment. These are our patients from Arnsberg, which we included in this registry. And what I would like to show you is that we mainly use the 10F system, and some of the patients we use the 8F system. And what's also very important is to show that old patients, nearly all patients, needed a stent afterwards, meaning after thrombectomy, you see an underlying reason, a compression syndrome, lymphocyte, cancer-associated stenosis, which has to be stented. And the other thing I would like to show is that we also in our patient did not need any thrombolytic therapy. Only 2 patients we gave because of a bowl filling bolus of TPA, 10 milligram TPA. No patient received prolonged thrombolytic therapy because we finished with all patients in the cath lab with an effective thrombectomy. And here's a typical case example. In a 20-year young female patient with a descending deep vein thrombosis because of a May-Turner syndrome. We gained access via transportal approach using 8F aspirates, and after 2 runs in the middle of this slide you see there's already an inflow, and after this of course we had to stand the May-Turner point, and after this we achieved a very good inflow situation in this patient, and we also in this case finished in the cath lab in 1 session. What we found out in our patient was we had more female patients with May-Turner associated DVT. Cancer patients showed up with more phlegmasia symptoms. The duration of symptoms were between 1 day and 3 months. And we achieved hemodynamic technical success in the cath lab with the aspirates device and stent implantation 100%. As I mentioned, we did not use prolonged lytic therapy, just TPA bolus in 2 patients. The stent rate, as I mentioned, was 100%. Stent rate was 1.25 per patient. We did not have severe complications like bleeding or pulmonary embolism. We had 2 small perforation in the common iliac vein, which after stent implantation was not seen any longer. And we lost 1 wire which had to be snared without complications. This is another case example, 81-year-old female patient with descending thrombosis, and after thrombectomy with a 10F aspirates system you can see a very nice inflow here, and also in this patient you see high-grade stenosis in the May-Turner point, which of course has to be stented afterwards. And this is the reason why the stent rate is so high in this approach. After effective detachment of the thrombus, you find an underlying reason which has to be stented. We also use this catheter for patients with other upper limb DVT. In this patient with a thoracic inlet syndrome, young female patient. In this patient, we performed thrombectomy with the 6F aspirates system. Of course, no stent implantation, but you can see here, of course, the very nice hemodynamic outcome also in this patient using 6F aspirates. So these are the technical tips for the usage of the aspirates. Please use systemic anticoagulation, no local anticoagulation through the sheet. Flushing is very important, the same as in the Rotarex procedures. Always take care of the guide wire. Interrupt the procedure, as Ralph already mentioned, for flushing the catheter. This is even more important in the vein system. The larger the aspirates catheter is, the more avoid friction and curved angle, especially in 10F patients. And we treat this patient afterwards with aspirin and anticoagulation, which is due to the guidelines we already did. We see that the aspirates has some pros in comparison to other thrombectomy devices. This is a pure mechanical thrombectomy device. The age of thrombus is not so relevant. We even treat patients with thrombus age of 3 months. We have a chance to finish in the cath lab. The problem is we do not have any randomized controlled trials data today, so we need definitely these data in the future. This paper was recently published, which showed that the aqueous device and the ultrasound-enhanced thrombolytic therapy seems to be not working sufficient in the system. So at the moment, we can clearly say that mechanical thrombectomy seems to be the best approach for treating patients with descending deep vein thrombosis. Thank you very much. So I think we can grab 1-2 questions from the web, and then we change to the second part of our session. There's a question here using of a filter for patients with DVT. Yeah. We do not use filter devices in treating patients. I don't know what the other colleagues think of a filter indication, and this is also not no indication, especially because of the high negative pressure this catheter creates. The pulmonary embolism rate is very, very low. We did not have any severe problems of pulmonary embolism. All patients were stable, and this is the reason from my side not to use an filter, especially in these patients. I think that filter even harm patients, and I think this is a more effective way to use just a mechanical approach. So, okay, I think we finished with that part of the session. I would like to thank Straub for the support of the first part of the session, and we now turn to the second part of our session now, which now is taken over by Ralph Longhoff, who brings you through the second part of the program. And also in this second live session, we have a recorded case, and Ralph is going to give you more updates on that.
Okay, so just for the second part, I think we can immediately go to the live case, and then we just have some lectures about the one system we want to present. It's the Aero GPS catheter from Teleflex, which is very interesting, and the case we are going to go through right now will deal with this special catheter, and then Mariana Brodmann will also give a lecture at the end about drug-eluting balloon technology, and I will just give you a brief presentation about the catheter which had been used in a live case here in Arnsberg.
Okay, welcome back here in the Arnsberg Clinic in one of our cath labs. Again, Marco, Mansi, and me are here to perform the second case. Also, one of our assistants is here with us, and we now have a 71-year-old patient with a Rutherford 5 situation with a necrosis of his D1 digit on the left side. This patient is on chronic dialysis, diabetic patients. And we now try to revascularize below the knee. We will shortly show you the angio. What we now do in the first step is to find access to the common femoral artery, ultrasound guided, and Marco is showing us how to perform this right now. So this looks quite nice, yeah.
Oof. Have the torque, please.
Okay.
Can we have the reference imaging on the other side?
Yep.
Direction is not bad, but
Yeah.
or is collateral. or we are subintimal. If we are subintimal, it could be better. Try to change a little bit direction. As you can see, I'm using the cutter.
Yep. So, subintimal or intraluminal?
Yes, should be subintimal, but we have flow.
Marco, what do you think of putting in the error GPS now? And Marco, I think we have to discuss a little bit on the guide wires and the support catheters we use in this case.
Yes, of course. We could see there was a tight stenosis, but an occlusion of the above the distal anastomosis of the bypass. So the first attempt usually is performed with the V18 guide wire, rotating in order to stay intraluminally. In this case, it was very difficult to maintain in the middle of the calcification of the popliteal tract the path, the intraluminal progression of the wire. So I was obliged to shift into a subintimal dissection, and with the loop we could reach the bifurcation where it was possible to find out a re-enter door for the anterior, and as a next step, re-enter door for the peroneal artery.
Maybe you can briefly comment on the catheter.
Now we see the preparation of the error GPS catheter, which the main important thing is here why we use that catheter in this particular patient is to find our way in this total occlusion, which is very helpful, and Ralph will give us later a detailed idea of this catheter, which is a 2-in-1 catheter, a proximal valve where we can inject the contrast and a distal balloon. So it's a 2-in-1 balloon catheter, which is very helpful when you are in a total occlusion situation to find the way. You don't have to take out the wire, and this is the real advantage of this catheter. Now we advanced this catheter. I think it was a 2.5, Marco. In this
yes, this was a 2.5, but it was a very long balloon. So the problem is to have the two markers for the valve where we can inject the contrast medium, few ml, 2 ml are enough, and we expect to see, as in the window, this kind of aspect. So we can really see through the occlusion. But it's important that the valve is in the occlusion, in the occluded tract, and in this case we had the markers very high in the. But another opportunity is to inject directly drug as a dilator, even thrombolytic drugs through the balloon in order to have a more favorable outcome and a more favorable opacification of the occlusion and the area below the occlusion. When we decided to change the balloon in a shorter one, it was 8 centimeters.
That's correct.
If I remember well, this would will be clear. I think the use of the shorter size is useful to advance using the balloon as a support catheter and advancing and inflating the balloon and then checking, especially in the patient with a borderline creatinine. So where is really important to reduce the amount of contrast medium.
And just to make it clear, as you said, which is very important, I think that if you just choose a very short balloon, so you just have the opportunity to give a super selective angio shot, just not to fill collaterals, but just to see whether you are already re-entered in the true space, or if you're just still subintimal or just far away of the vessel you want to treat. So that's the advantage of this short balloon, as you already mentioned, that you can stay super selective and that you're not filling collaterals.
And of course there is no need to remove the wire to check through the balloon, because we have this particular mechanism of the open and close the valve, and this could be really an advantage during this kind of procedure. So probably in this phase we inserted the shortest balloon.
We also have to mention this is a 4F balloon, which is also very, very helpful for an undergrade approach. So you can even stay with a total 4F approach. But in this case, we use the 6F approach. But if you want, you can stay with 4F.
And it's running on 014 wire.
Yes, it's the balloon is running over a 1/4 wire. There are no limitation in the kind of wire, so you can use high support wire or high tip load wire as hydrophilic wire for navigation. So you can shift from an intraluminal progression to a subintimal progression, so making a loop.
So it's just it is safe in terms of you are not going to damage your wire as you may face when you use outback or off-road or other devices where you should not take a wire with a polymer sleeve, but in this special dedicated catheter you can use any wire, any 014 wire you like to.
I mean, you mentioned that it's very clear where you are when you're using this catheter in recanalizing such occlusions. So would you have the feeling that this might be better than coming from retrograde, so that you might spare retrograde procedures in the future if you use such a catheter?
Yes, the profile is not so small, but I think for selected patients, could be possible to, for example, if you perform a proximal puncture in the proximal part of the anterior tibial, that tract could fit even a 6 French sheet if you want. So it could be possible to use even a retrograde access this catheter. Yes, we performed after the first dilatation here an aspiration, and there were some debris inside. So after the aspiration, we arrived again with the second wire in order to divide the two vessels. Treating bifurcation is not easy. Well, what do you think about the options for the bifurcated lesion, bifurcated vessels?
So I think it's mostly really challenging. So it is a little bit more easy if you just have a retrograde access. So then you can go for the one with antigrade and the other for retrograde. So this may save the bifurcation lesion. But I've seen, I think, some of your procedures during LINK that you sometimes go with a second catheter. So as you did here, you just have one wire and the other one is running on a Berenstein catheter, and you just have two options, which is very elegant. But I think it's
Yes, the same we did here
You need
with two
time.
wires in order to divide the vessel. The problem is when you are subintimal, sometimes you may have two different doors in different levels. So when you dilate, there is a flap in the middle. You may save just one vessel of the two ones. So the other option, Michael, what do you think about the reconstruction of the bifurcation?
What we did here in this case, maybe we can already discuss this. We implanted a drug-eluting stent in this case.
You could see here the flow through the catheter.
And Marianne, would you go you would go for a drug-eluting balloon? You're one of the BTK specialists. So would you go here for a DAB? And what would be the option if there's still flow limiting dissection and afterwards?
I mean, you have to look for the technical outcome. I mean, if you say there's a flap and you see that there's a mechanical issue, I would go for a stent and then a drug-eluting stent. Otherwise, I just would try primarily a TEP. Yeah.
Stay with the DAB alone.
Stay with the DAB alone. Yeah. But if I see that there is technical problem, there's a mechanical problem, then I would just maybe go for the drug-eluting stent right away.
Right away, yeah.
The problem is the length of the drug-eluting stent. This is a problem. I mean, we are limited in this space.
That's correct. Yeah. So now we are down at the foot, and we start to recanalize now the anterior tubular artery. We went down.
In this case, there is a particular anatomic variation. So we didn't have the dorsalis pedis. There is only a tarsal artery for the tarsal area. We know that in 12% of patients we do not have the dorsalis pedis. So it was not indicated to try to recanalize the artery because there is no artery. So it's a hypoplastic artery.
So, but in this case, you already opened the P3 segment and went into the anterior?
Yes.
Okay, and now you try to get to the trifurcation.
No, we have already a wire into the peroneal,
okay,
and the second wire into the anterior. And then after the angioplasty in the ostium of the anterior, that was particularly difficult to be engaged because of a calcified plaque involving the ostium and the first tract. We decided to do a next step treatment. You can see here the outflow and the absence of dorsalis pedis there.
It's a typical anatomical variation.
Yes.
Yeah. So it's mainly the plantar lateral artery.
Yes, there is a medial plantar artery patent and probably a suspended tract of the lateral one, but it was not possible to recognize the ostium of the posterior from peroneal trunk. So
in this case, which catheter did you use to follow the guide wire?
we used the GPS catheter.
GPS,
right,
still the
yes.
GPS, okay.
Yes.
Yeah. This is also a very good support catheter. So it's even a 3-in-1 catheter. It's also very good for supporting.
But coming back to the support, maybe for the audience listening, do you recommend the longer balloons or the shorter length of the balloons for the support? I mean, if you use the GPS, because I think that the shorter ones give you more support.
They give you more support,
Yes,
definitely.
yes, for sure,
correct,
for sure.
Yeah. But you have the opportunity to use long balloons for just one inflation, and this makes it also very interesting for long CTOs.
So you said this is a 4F system?
Still 4F system, so this is very, very
which limits the balloon size to
1.5 to 7.
7.
So a very small one, but even just large ones. So you can use it also for an iliac, or just also very well for SFA.
So this is also very interesting for long SFA occlusion,
Yeah,
of course,
yeah.
where you have to find a
Yeah.
way downstream. So now
So this was the result, and we can see the
now this
the
is
plaques, the bed plaques.
still black. So this is after ballooning.
Yes.
And now we decide to go for standing of the popliteal artery.
Yes.
Because we did it subintermally. You see, it starts directly behind the anastomosis of this bypass.
And I mean, I have the impression that there's calcium there, so
Yeah.
Yes. Yeah,
removing the calcium was not.
It was severely calcified, the tract.
Mm.
So we need to scaffold.
Yeah. So we implanted here a stent in the popliteal artery. The whole P1 to P3 segment with a biomimic stent. It seems to be a very good stent for this indication. Did a post dilatation with a DCB, and then went in with an debulking device, with an atherectomy, to get out the organized material of the origin of the tibial arteries and the preaneural. We use the Phoenix system, and we'll see this in a second. This is now the run-in after stent implantation. You still the high calcification situation in P3, the origin of the tibial artery, and that's why we said, now we have to perform an atherectomy.
Yes. Yes, in fact, atherectomy device could be another good option to treat the bifurcation. We used to maintain a second wire just to protect the second vessel when you perform the atherectomy.
And this is the Phoenix system, which runs over a 0.14-inch wire, 2.2 millimeter diameters, and this can clearly clean up the situation down there. Really debulking atherectomy system. We performed it.
So it's a rotational device, or
It's a-
front cutting?
Front cutting rotational device. Yeah. And the advantage is setup is very fast. Half a minute setup.
And it's sucking out material, or okay,
It's working with the achematic principle, like the Rotorex. Yeah.
it's a little bit like Jetstream, similar to this, or different kind
Different
of.
because Jetstream has no achematic principle. It's a different principle, and this is a real screw which is inside the spiral and inside the catheter, which take it out.
So compared to other atherectomy devices, this is the one you're using routinely.
Below the knee.
Below the knee.
Because it has diameter of 1.8 millimeters to 2.2 millimeters. So it's not a good option for SFA.
And how far down are you going until?
As far as you want.
As
Yeah.
far as you want.
We were even in the dorsal pedis artery. So, but afterwards we were still not satisfied. That's why we implanted now a drug-eluting stent. Down, as we already discussed. If you still have a flow-limiting situation, that's why we now implanted a drug-eluting stent. It was a 3.5 millimeter biometric stent here, and this was the outflow afterwards. So an open tibial artery. The patient has an D1 ulceration, so we will see what the ulceration will make during the next weeks and months. And maybe we have to go for second approach to reopen the posterior.
Yes,
artery.
I think the target vessel could be considered the posterior tibial artery in this patient, because the absence of the communication through the arch, the lesion were, I think, in the second, third, or fourth, fifth.
Digit 1
Yes.
and a little bit digit 2, mainly digit 1.
Okay.
And just going for the posterior as a first approach was this not an option because you were not able to go through, or?
Yeah, it was very difficult to reach it. Yeah, maybe this is something for retrograde approach. More easier.
Okay, so just I want to give a lecture briefly about the Aero GPS catheter, but maybe just beforehand we can just ask or go to two questions which are here from the audience in the web. And they're just addressing the drug-eluting balloons. So how to improve long-term results of endovascular procedures in CLI, and when do you use DEB below the knee? So maybe we can just address this. So did you use DEB after atherectomy in your case?
Yeah, this is our approach. We do mainly in these patients. We do debulking therapy and combine this with DCB. We recently saw the result of definite IR. Thomas Zeller presented this recently, which gave us an idea that this combination therapy works. There was not a significant improvement, but there was a clear tendency. What do you think of this combination, debulking plus DCB?
I mean, I think we need some debulking system for below the knee. I don't think that ballooning alone, whatever kind of ballooning, might be the solution at the end of the day. So I'm, I would say, a fan of this combination therapy. And I mean, after results have come out and have been presented with a hint that it might be better than just simple whatever, we also have changed the approach, and you see that there is a lot of debris there's a lot of thrombus there might be a lot of calcium there, and there are longer lesions than usually in the SFA. So I mean, I think DCP might improve the outcome in some patients, as we have seen in some trials. One trial has proved to be negative, but I still think that we need something in below the knee which is additional to the mechanical, like DCP or stenting. So I think we need something underlying to remove calcium or thrombus or whatever there.
Yeah.
Yes, in order to facilitate the penetration of the drug into the vessel wall. Otherwise, all the drugs could remain or in the thrombus or in a...
We have a smaller vessel
calcium.
diameter, and we have the calcium, so we don't know where the drug is going through. And I think the reason for the failure of the trial was that we were not applying the drug really completely to the vessel wall. I think that might be one of the issues why the outcome is not as good as above the knee.
So I think we're just not talking a little bit about complex lesions, and if you see for all those trials which address more complex lesions, which means SFA lesions longer than 8 centimeters, where DEB was quite good. So you see that most of the trials are addressing atherectomy plus DEB, DEB plus stent, stent plus DEB. So it seems to be that the combination of drug-eluting balloon plus another additional technology, which means plug removal, or just to get a little bit more into the calcium, like with Angus score, or just
whatever,
seems to be a more valid option. So just to improve,
and I think also cost effective at the end of the day, even if it's more costly just at the initial procedure. But if the patients are not coming back for another procedure and don't have to be readmitted, maybe it might not be for the fun of the hospital. I mean, at the end of the day, it might be cost effective if you do a more costly procedure just at the beginning.
Okay, so I think maybe I can present on the Aero GPS catheter with my lecture, and then we go with the second lecture from Marianne Brotmann, and then still maybe we just have time to discuss about the case and just about different indications. So I just titled my lecture just the Aero GPS catheter to minimize the risk of radiocontrast-induced nephropathy and to optimize imaging and technical success, because I think this is just going to wrap up most of the important issues which are addressed by the Aero GPS catheter. So if we look for our typical environment we are just having to face in our cath lab today, I think we just treat patients which are not young patients. The age is just mostly more than 70, 75 years of age. Most of them just have diabetes, hypertension, they suffer from heart failure, they are dehydrated, they use non-steroidal anti-inflammatory drugs for other reasons, for their comorbidities. They use nephrotoxins like diuretics, like ACE inhibitors, just for treatment of hypertension. And most of those cases are just urgent or priority to the procedure, so they are not elective cases. And the procedures itself, so mostly we just have to face multi-level disease. Mostly they are going to include BTK interventions. There are CTOs, we see more and more calcified lesions, approximately 40% of those cases. And I think there is a trend that the usage of O14 and O18 wires is just becoming more and more. And I think all those patients here, they qualify for radiocontrast-induced nephropathy, and just the procedures itself, they also qualify for high volume of radiocontrast. So I think it's just a quite important option. We have the patients, but we can just work on the procedure itself just to optimize it here. So is nephropathy important or not? And there's just one publication from 2009. They look for PCI interventions, more than 500 here, and look for endpoints. And if you just look for the endpoint here of giving more or less contrast, you see that the endpoint of death was just, if you just use more contrast, you see you have a 4 to 5 times fold increase in the rates of death. So it seems to be in all those endpoints here that the amount of contrast is just really of great influence, even just for hard endpoints like mortality. Just to prevent this radiocontrast-induced nephropathy, I think we just have to select proper patients, which is difficult because they're going to come and they just have their problems. So we can avoid contrast by using CO2 angiography, which still has some limitations because, especially below the knee arteries, you cannot really optimize your imaging, even if you just have the machine, and it's probably you have more radiation you have to use. You can reduce the contrast. So this is strongly depending on the equipment and on the technology you're going to use long sheaths going directly into the popliteal, and maybe just using also the aero GPS catheter, which is also enabling us to save contrast because you just only need maybe 2 millimeter per shot to have a good image. And you just have to use proper patient preparation, which in terms of timing can be somewhat difficult, but I think you just have to hydrate those patients as much as possible and just to stop diuretic therapy. So what do we need for complex interventions? And as we just already have seen, that these interventions we've seen here from Arnsberg are really complex interventions. I think we need more and more O18 and O14 wire-compatible balloons, which are on the market right now. We need a good portfolio of balloons, and just talking to the mentioned catheter, it's available from 1.5 to 7, and just in diameter and in length going up to 21 centimeters, offering, I think, good options for complex BTK lesions and also for SFA lesions here. I think we need something which should be pushable. The pushability is good, and as already said, it's a braided catheter, so it's stainless steel braided shaft, so there is pushability in this catheter, although the profile is just not comparable to other O14 balloons, but it is compatible to other O18 balloons, so it's a good workhorse tool also. Stable wire position, that's quite easy with this because you do not have to remove the wire just to inject. You have to have a good visualization of the lesion, which is quite nice, and you're enabled to have super selective angle shots here to see side branches, to see the pedal loop, and just to define your culprit lesion which you wanted to treat. So as said, it's a 2-in-1 functionality, so you can use it as a semi-non-compliant balloon, and you can inject via using your visual valve here. And to show this here in this picture, so you see this handle, and there is a thumb slider here which is going to enable you to use either the balloon technology just to inflate the balloon, or just if you push the thumb slider forward, you can use it as a diagnostic catheter. So that's the way it is going to look like. So you see the balloon one, and here you see the place where the visual valve is going to enable you to get some contrast into the vessel directly in front of your balloon. So that's why for CTOs, as we already said, that a shorter balloon is better to use as a longer balloon, because then you're directly in front of your lesion. So that's a picture from Marco Manzi, where he used the balloon here in a pedal loop. You can see that the balloon is in place, wire is still in place, and you see at the small pictures showing you the image that he really was right to tackle here the pedal loop, and that he had got a very sufficient and good angiogram by using this balloon here. To summarize, I think key benefits are just its innovative 2-in-1 technology, and allows complex procedures to be performed using only one catheter here. It's quick transition between the two modes of semi-compliant balloon, high pressure balloon. No need to adjust guide wire position. Reduces the risk of losing access. It can save time and also procedural costs, and may help to enhance patient outcomes. And at the end, you're saving procedural time, you're saving radio contrast volume, you're saving radiation exposure time, and by using only at least one tool. Thank you. I think that was just a brief overview to get you a little bit more familiar with this new technology. And I think maybe it would be good to go to some questions here.
So after this balloon angioplasty, how often do you use drug-eluting balloons afterwards then in BTK?
So we are still a little bit afraid of using drug-coated balloons. So in case we talk about CLI patients, we would rather use drug-eluting stents today in very short focal lesions. And if it's we would even more go for long balloon inflation times. We're just really, really limited in below the knee arteries. We use this in in-stent restenosis and SFAs a lot, but below the knee, I have some considerations right now. So we try to get those patients into trials, and just have the Biolux P2, where Mariana was very active. It seems to be safe in some technologies, but efficacy has to be shown. And we know that some technologies are really harmful, as we have seen from Impact Deep. So I think we just have to wait for more data.
Okay.
So there's one question: how much contrast do you save with GPS, and why? So I hope I answered the question why. And to save contrast, so in most of the cases, if you just have a small syringe, because the valve is very short, so if you use a 5mm or 2mm syringe, it is efficient to have a good image with 2mm of contrast, to see the outflow situation and just to get a good image of the part you treated. So that's, I think, if you go from the sheaths, you would always inject maybe 8 or 9 or 10 cc, so you just save a lot.
And I guess you can still dilute it in the 2mm syringe.
Yes, of course.
So
Dilute
then
it.
you can then up with 1mm, something like that. So it's really very, very small amount.
Yes, procedure could be performed with less than 20 ml of contrast medium diluted. So I think it's more than acceptable in this range of patients. So,
So
Sure.
just a short technical question. So you have a valve, and I understand that you can flush the balloon or flush the
Yes,
extraluminal portion.
you can decide by using the thumb slider. You're just deciding whether you want to inflate the balloon, or if you just put the thumb slider forward, you just can use the hemostatic valve, and you can inject. And it's an ordinary balloon, as said, but it is offering, due to the braided shaft, it's offering also the option to give contrast directly in the working field.
Is blood reflux into the catheter or even in the balloon so a problem, like clotting inside?
No, in the balloon not, but there is, so you can suck a little bit of you have negative backflow, yes.
What you can even do is you can connect the balloon, the larger size of the balloon, with your automatic infusion system, contrast infusion system. Yeah, you can stay with a low flow rate so that you can really transport the contrast through this vision valve very homogeneous. And this is also very, very helpful. Yeah.
And I think the time of the procedure is also a little bit shorter because you stay at the lesion side. You don't have to move, so you don't have to move the table. You just stay at the lesion where you want to get the image. So I think it's very comfortable.
Okay. So there's just one interesting question here. How long the dual antiplatelet therapy after CLI procedure? Any advice from your side?
I don't think that we have. Sorry, Professor Manzi. No.
3 months.
Okay.
3 months. We use in our protocol 3 months dual antiplatelet, so ticlopidine or clopidogrel and cardioaspirin. Then after 3 months we stop with the ticlopidine or clopidogrel and aspirin for life.
Okay. So
more or less
monotherapy
this.
lifelong, and dual antiplatelet therapy you say for 3 months. We also would say if we use a DEB for 3 months, and if we just cross a CTO, we would just say maybe 1 month. But there's no data. It's just
Yes,
everything is
we
just
don't
belly
have
feeling.
data.
It's belly feeling, but probably it will be different in Arnsberg, Berlin, Graz, Krefeld, and
No guidelines.
Abanoterme.
No guidelines.
So there are no strong guidelines, but it is something between 1 month and 3 months, I would guess.
I mean, if the patient is coming back with a reobstruction, I think then you should at least stay to 3 months if you want to do a re-intervention.
Or maybe 6,
or maybe
a
6.
year.
But on the other hand, I mean, this critical emphysemic patients, to make it even a little bit more complicated, have a lot of these patients have AFib, and then you're, then it's getting tricky. What kind of therapy are you applying to this patient?
Okay. There are 2 questions here concerning retrograde puncturing. So if it is safe if we just have a single vessel, and how do you close the retrograde puncture site? So maybe I can just comment on the last one. So mostly if we succeed to puncture and go, we would go for internal compression by using a balloon. Very gently, just a 2 millimeter balloon or 2.5, depends on where we just puncture, and then close it. But it is mostly not a big issue to close the hole. Yes, and if it's safe, it depends on your skills, honestly speaking. But maybe you just have comments, because in Abanoterme you have very
in this
critical
case,
ill patients.
the only distal leg artery patent is the anterior, but it's not the object of our retrograde puncture, because the option is only in the lateral artery in order to recanalize the posterior tubular artery. So if you fail, there are no damage on because it's occluded. So it's safe in this case.
Okay.
And I really think it depends on the skills, as you have said. So I don't think that everybody should start with everything right away. So
Yes, it's always a rescue procedure.
yeah.
But honestly
For us,
speaking, if you just look for the conferences like Link, and if you see just a lot of those live cases in just hands of skilled persons, I would say it is a very safe procedure. But I think you have to be trained, and I think you should not, as Marianne already said, should start with the worst cases where there's only maybe one single vessel left, which
Yes,
you
of course.
do not want to jeopardize for bypass landing zones.
But I think as you said, it's a rescue procedure. So if you are not able to come from the antegrade approach and do all the things you want to open, then I think you should do it as a second step. So I think this is our approach, and this
Yes.
is a good one in our opinion.
Yes, I agree completely.
I think we should move maybe to Marianne's lecture.
Do you have a point?
Yeah,
too?
sorry.
Thank you. Okay. So how important is vessel patency and how they achieve it? So at the end, I just want to come to the TCP as an option to do that. The outcomes of patients with critical emphysema, we have just seen that this is a really bad fate they have, so that a lot of patients are dead or have legs amputated after 1 year if you're not able to do a revascularization. And there's this so-called diet over concept that you have to have an approximately 30 millimeter Hg to perfusion pressure to prevent ulcers, and to have a minimal perfusion pressure to allow ulcer healing, which is 80 millimeter Hg. If you are not able to do a revascularization, then you have a very high grade of amputation, 60% nearly, if you're not able to do any kind of revascularization, and this is also in accordance with the survival of this patient. So if you're not able to do revascularization, then these patients are going to die. So in my opinion, I think that PTK interventions in patients with critical lymphedema patency is a matter of discussion, and it matters. There is this meta-analysis from Rometti in the Journal of Vascular Surgery saying that long-term patency is not so important for lymph storage, but I really think that it is important. As this recent paper has shown us, that restenosis delays the healing of, and therefore tibial patency matters in my opinion. On the other hand, we have the issue that in nursing home patients, for example, if patients are immobile already, they don't get any benefit from revascularization. So we have to do that before. How can we gain sufficient tibial patency? I think BOBA is the worst. Can we do it with surgical treatment? Yes, but only in selective patients. And when we look at the recently presented data from the British registry, which has been presented at Charing Cross this year, then this is a registry in Germany conducted at several sites. We see that we are going more and more from surgical procedures to revascularization procedures, and that revascularization procedures are the ones who are possible, and the surgical procedures are not that possible anymore. BOBA treatment, we see that we have, as already mentioned, even with the newer guide wires, not that good long-term patency. So maybe bare metal stents, is this an option? We also have the data from RAND that this is not the ideal treatment at the end of the day. We have discussed already drug-eluting stents. I think this is a good option, but as we already have mentioned, it's usually only for spot stenting, so we cannot cover the whole length of the lesions we need to be treated, and this is a problem too. Coming now to the TCP technology. So we have the one trial which has failed, but we have also positive hints which are existing, especially the trial from Listro. The PTK wound care was applied in a standardized manner in this PTK registry, and we see that with the TCP and with standardized wound care, this might give us some improvement in patency at the end of the day. This is the IMPACT Deep trial, which failed to meet the primary efficacy endpoint concerning late lumen loss, and there was no difference between the TEP and the PTE arm, but concerning clinically targeted lesion revascularization, it was a little better off in the TEP than in the PTA arm, but primary safety was the concern at the end of the day, and therefore the trial really failed. These are the secondary endpoints I have to skip for time reasons, and I think that the most important thing in this trial was that it was a different TCP, and that we cannot say that TCP is not working in below the knee, because I think in the meantime it's a clear issue that the TCP for below the knee in this trial was not an efficient TCP. Ralph has already mentioned BIOLOGS 2 trial, where we have some hints. It's a small sample size, but the proof of concept, and also the one-year data, they have been presented to Euro PCR and show that there is no more amputation at the end of the day, and the rate has not changed. How can we gain sufficient tibial patency? We have several problems of PTK. We've already discussed the risk factor diabetes, the higher cardiovascular risk population, calcification, what should we do, debulking, what kind of debulking. We have longer lesions, we have smaller reference vessel diameters. We might have the issue of coding. We are not sure if we have the right drug for below the knee. So this is still a matter of discussion, in my opinion, and I think what is also very important is that in PTK, the outflow, the runoff to the forefoot is a very, very important issue which we don't address that much as we should. How can we gain sufficient TPO patency? We have a new trial on the way. This is the Lutonix BTK trial, where we might get some additional insight into the DCP technology, but at the end of the day, I don't think that DCP below the knee is a dead man walking. Thank you very much.
Perfect. Thank you, Marianne, for this overview for using DCB below the knee and for patients with critical emphysema. To bring it to point, how do you perform in your daily routine business, DCB below the knee, now focusing the Impact Deep trial? You're using still in routine assessment DCB?
Ralph has already mentioned it. We try to gain data, so we try to really put as many patients into different trials concerning different concepts first. Second, we use it routinely in patients who are coming up with free stenosis, for example. So if a patient is coming back with a critical emphysema and we have done the procedure already once, then for the second procedure we use a TCP. But we don't use the TCP alone. We try to do some debulking system, some debulking, whatever technology, atherectomy, angioscalp before, or whatever, just to prepare the vessel and to do a proper pre-dilatation, which I think is a very important issue. As you have already mentioned it, we are not able to bring the drug into the vessel wall.
And every DCB has to prove its own efficacy and safety.
This is still my meaning at the end of the day. I don't think that all DCBs are the same. So they have not the same coating. They have not the same balloon material, which is the platform. So they have to prove their own efficacy. It's like a drug. We have moved from a technical point. We have gone in the new area, which is a like drug trial.
Perfect. Okay, thank you. It's 5:45, and we already get a sign from the organizers that we have to come to an end of this session. I think it's the moment we have to say thank you to all the organizers, to all the supporters of this session. I think these sessions are very helpful to bring very important points in the endovascular field in the community and to discuss it very objective and especially important issues we have today, which you're focusing on today. Thank you very much to the faculty members here. It was really a pleasure and an honor to have you here. I think you're one of the most experienced colleagues in this field, and so I think we gained a lot of very important answers today. Thank you very much also for the community who joined us. We received more than 200 questions. So far I can say we were not able to answer all questions, but you can still put these questions on the live web, and we try to answer them during the next days. Thank you very much. Have a good evening. Have a good afternoon. See you soon. Goodbye. Thank you.